So in the first line setting, in those patients who do not have actionable oncogenic drivers, the standard of care is chemotherapy. In advanced disease, it's really choosing the appropriate platinum-based doublet, which we base upon histology of the patient. We kind of think of squamous options as different than non-squamous options. This gentleman with large cell carcinoma obviously has a non-squamous option. So the two platforms of platinum-based doublets I would consider in this gentleman would be carboplatin with either pemetrexed or paclitaxel. There are others, but I think in practice today, those are the two that rise to the top as the two first choices. The other option that we consider is, do you add a drug like bevacizumab, an anti-angiogenic agent, to this patient? Certainly he fits in the non-squamous diagnosis category, so that would be a consideration. We know that he has no brain metastases, so that's not an issue. The history tells us that he has no history of hemoptysis. He does not have any significant comorbidities that would make me shy away from a drug like bevacizumab. He is 72, so I think age is a consideration. There's no absolute age in which I would decide not to use bevacizumab, but I think the data suggests that with increasing age, you run the risk of increasing toxicity. So this gentleman, I would probably recommend most likely carboplatin paclitaxel plus bevacizumab. I think if there were concerns about toxicity, for instance, if he had any evidence on history or exam of some baseline neuropathy, or he had a wonderful head of hair and alopecia was important to him, then I think it would be very reasonable to use carboplatin with pemetrexed plus bevacizumab, and that would be based upon their equivalent outcomes in the Point Break trial.